Thank you very much, ma'am, for such an elaborate introduction. At the outset, I'll first thank Professor Savas, Dr. Gokai Alpak, and distinguished speakers and moderators on the dais, as well as the august gathering. I feel honored to be here amongst you, traveling from India. And today I'll be talking about therapeutic drug monitoring in bipolar disorders. As we all know that bipolar disorder is a serious, chronic and recurrent mental disorder. It has a high prevalence of 1 to 2% in general population. It has got serious impact on patient's life, where we see there is a decrease in the functional capacity, a person's self-care, and because of the socially unacceptable behavior, the person many times gets into troublesome situations, and at the same time, at personal front, the interpersonal relationship issues occur. So in all, there is a lot of problem associated with bipolar disorder. Financially also, if we see, there is a huge cost of burden on the patient, because mostly he is a bread earner of the family, and the days of daily living, they are hampered because of his being infunctional and not able to attend to his routine, as well as the therapy of the therapy for the long treatment because of the chronic nature of the illness also has a cost attached to it, which includes even the hospitalizations which are required and also the laboratory investigations. So there is an extensive morbidity which is seen, and the availability of effective treatment again is a problem, as it was discussed in the earlier presentation as well. I would not like to go into detail, but we have seen out of our own experience that almost 40% of the people respond to the first primary therapy, and then a second line of therapy has to be initiated, either an adjunctive therapy, add-on monotherapy when it doesn't work, then polypharmacy sometimes has to be done for patients with bipolar disorder, which show that the effective treatment in terms of monotherapy alone doesn't exist. So how do we improve the outcome in the bipolar disorder? We have to look at the usefulness of psychotherapy for improving treatment adherence and clinical outcome of bipolar patients. Then we also need to understand that pharmacotherapy with psychopharmacotherapy as a mainstay has to come in, where it fills in the gap where there is a difference between the theoretical efficiency and the real world effectiveness. So hand in hand, they both go together. Now, coming to the mainstay of my talk, monitoring in bipolar disorders. When we talk about monitoring, we'll talk about the psychiatric and the medical monitoring, wherein patients with bipolar disorder have got their psychiatric problem, as well as frequently we have seen that there are various comorbidities which are attached to these people, maybe because of addiction, maybe because of their other problems like hypertension or medical disorders. So they all need to be monitored together, which we will know later why we are emphasizing on that now. Then monitoring of the bipolar symptoms. The symptom profile needs to be regularly monitored, and hence it would require the dose adjustments accordingly. Monitoring of the drug levels, monitoring of adverse events during the course of the treatment, monitoring of treatment adherence, as this is a chronic illness which is a long course, so treatment adherence is very important. Then monitoring of psychiatric problems like suicidality, suicidal thought and ideation, and mood switches associated with the drug therapies. It has been seen that with lamotrigine and a few other molecules, there are switches from, like manic switches, which are seen during the course of the treatment. So, A continuous pharmacological treatment is needed to control bipolar disorder. The adherence to medication is important for a satisfactory response. And there are many factors which contribute to the poor adherence. May it be the person's own lack of psychoeducation, may it be because the person feels that there is a remission of illness and hence he does not require so much of treatment now. And other factors may be the cost burden, sometimes maybe the ease of administration of the medication. There are many factors which contribute to poor adherence. So quantification of serum or plasma concentrations of drug for dose optimization is required. And we also see therapeutic drug monitoring as a valuable tool for the patient-matched psychopharmacotherapy. Now we see that the relationship between plasma concentrations and clinical effects has been talked over time and again in various research papers and journals. While we are talking not only about the therapeutic improvement, but also associated side effects and adverse effects which are associated with dose. Sometimes we see that they are dose dependent. So whenever we are looking at something which is dose dependent, the plasma concentrations become important. Many drugs like lithium have got narrow therapeutic index. So the plasma concentration range of the drug, which is characterized by maximal effectiveness. We want that the benefit should be the maximum and the safety at the same time should be maximum when we have the lowest adverse event profile. So, the dose optimization requires therapeutic drug monitoring because after initial prescription, when we are saving the patient, we start slow, go slow, and then gradually enhance the dose according to the symptom profile. So, while we up-titrate the doses of the medication for optimizing the response, we do drug therapy monitoring. And it's mandatory for safety reasons, as we have seen for lithium. Sometimes we see that there is a partial or complete non-adherence, which by me I mean is non-compliance to the medication. So in such cases, when you don't have any reliable informant and nobody to supervise the medication at that time, the drug levels are the best indicators. Lack of clinical improvement under recommended doses. When we are looking at a patient who is not improving with a particular drug, and we, before labeling him as a non-responder or a partial responder, we should look at the drug serum levels to see why the clinical improvements are not there. Adverse effects and clinical improvement under the recommended doses. Then combination treatment with a drug known for its interaction potential or suspected drug interactions. As we will go through the slides, I'll come to these points wherein there are multifactorial things like there are comorbid illnesses and at the same time the person is on various drugs for other reasons and the drug-to-drug interactions also jeopardize the situation. Therapeutic drug monitoring in pharmacovigilance program, as we have seen that in various programs like NHS programs in UK, they are mandatory to report and this is reported to the system. Then relapse prevention under maintenance treatment. If there is there have been papers which have shown that those who have got stable dose on long-term treatment have fewer frequent relapses and recurrence under adequate doses. Presence of a genetic particularity concerning drug metabolism is also one of the indicators. Then we have the spatial population, the pregnant or the breast lactating females, children and adolescents, and elderly. These are the spatial group which requires close drug monitoring because of their own physical conditions. And individuals with intellectual disabilities. There are certain people with subnormal intelligence. In those, we cannot rely on the information given by them. Then the drug monitoring by serum levels is a better indicator. Patients with pharmacokinetically relevant comorbidities, like patients who are having hepatic insufficiency or having renal problems or cardiovascular diseases, In such patients, there would be on certain other drugs which are also going to act on the same enzymes as these drugs are acting upon, and hence the serum levels go high. Then the forensic patients, because of their own reasons. Problems occurring after switching from an original preparation to a generic form. Now, because of the generic thing coming into picture, to a large extent, this is a debatable issue which has come now, that generic or non-generic and the original molecule. And most of the time we have seen that the efficacy remains almost 85% similar, otherwise the government will not give them any kind of a permission. But still those 5 to 7% is sufficient enough for certain population to switch over into the current symptom or aggravation of the illness. So switching over also sometimes requires a close monitoring. Then drug monitoring in bipolar disorders may increase an early detection of subtherapeutic drug levels, which may be the cause of non-improvement, as well as elevated drug levels may be seen in certain patients. Then, to distinguish between non-response from non-compliance, many times non-compliant patients are labeled as non-responders, and then they are shifted to the second line of treatment in the algorithm of treatment. In such patients, before terming them as non-responders, we should look at the compliance issues. So regular monitoring of blood levels may improve the compliance by reinforcing the importance of taking medications as prescribed. That look, you are going to be evaluated every 3 months, every 6 months, your blood is going to be taken. So you need to be particular with your medications. And that psychoeducation reinforcements also improves upon the compliance. So the 3 pillars, if you see, control over medicine dose, determining the patient compliance, and detecting early signs of drug toxicity, these are the mainstay of therapeutic drug monitoring. If you look at the list of the most commonly used drugs as mood stabilizers, besides antipsychotics or antidepressants, are the basically anti-epileptic drugs which have all been tried time and again, where lithium, sodium valproate, carbamazepine and lamotrigine have been time tested and have got a lot of data to back up, while topiramate, tiagabine, levetiracetam and gabapentin are being tried now with plus minus results. Let's see, with more data coming in next 5 to 10 years, we'll be more sure about how good they really are. So looking at the standard ones, carbamazepine, as I was just discussing, like carbamazepine has cytochrome P 1A2, 2B6, 2C8, 3A4 and 5 enzymes involved. Lithium, although has no metabolism clearance, but valproic acid, if we look, has again got cytochrome P 2B6 as in carbamazepine. And if we see lamotrigine, it has got cytochrome P 2A6 as in valproic acid. So if sometimes we put the patient on 2 mood stabilizers, then the serum levels suddenly shoot up and go into the toxic ranges in spite of being into the therapeutic level as such told of. So while we are shifting them onto a second regimen, we have to be cautious enough and we have to do a close drug monitoring. The normal therapeutic reference range for us, the carbamazepine 4 to 10 mg per ml, lamotrigine 3 to 14, lithium 0.5 to 1.2 milliosmol, which can be said as 4 to 8 mcg, valproic acid 50 to 100. These are the standard ranges which are also for the anti-epileptic doses. And according to the guideline and consensus, these are the doses which, therapeutic levels which are also used in bipolar disorder as of now. So for lithium, valproic acid and carbamazepine, the therapeutic reference ranges and toxic levels are well defined. For lithium, therapeutic drug monitoring is the standard of care. As we know that there is a long-term use and an acute treatment phase. So for long-term use of lithium, plasma concentrations of 0.5 to 0.8 milliosmol are advised, while in acute treatment we can go as high up to 1.2 milliosmol initially. While in prophylaxis treatment of bipolar disorder, 0.6 to 0.8 millimol per liter is sufficient therapeutic level. And brain to serum lithium concentration ratio of 0.76 is a median concentration ratio. Toxicity normally appears at above 1.5 to 2 millimole per liter, and the lethal effects are also seen as high when we go up to 3.5 millimole. So we see that there are lethal effects and toxic effects also coming into picture because of the co-administration of a certain drug. Suddenly when these shoot up, so we have to be very cautious and monitor them quite closely. Lithium requires that. So this is the challenge with lithium, that it requires specific care because of its narrow therapeutic range, high risk of intoxication, slow onset of action, and it's subject to serum variation levels in a very high manner. Elimination and dosage plasma levels vary among people. It may be increased by a number of medication classes, like we were talking about renal clearance, if somebody is having a renal impairment, or if somebody is on a drug which is having the renal angiotensin mechanism, like thiazide diuretics, which lower the lithium clearance, or ACE inhibitors, or somebody is having a chronic pain and he's on NSAIDs. So in such people, suddenly the levels of these drugs will increase, and while they are also taking these off-label drugs, occasionally they should be cautioned that if you are taking any of these drugs, do let us know, and then the drug monitoring should be done quite frequently. And increased serum lithium concentration, sodium depletion, and signs like vomiting and diarrhea or fever, if they come in, then it also calls for a serum estimation. Then monitoring for patients on maintenance regime of lithium, serum level on routine should be done every 3 to 6 months. Thyroid function should be done every 6 to 12 months. Renal function should be done every 6 to 12 months for patients on maintenance of lithium. In older adults, when we are talking about older adults, they have got lesser blood volume, their liver status is compromised, and sometimes they have got renal impairment as well. So a careful monitoring for symptoms of lithium toxicity is there in our mind. Older adults may develop high serum levels at doses in the normal range. So by dictum, what we follow usually is that half the dose of an adult is good enough for an older adult. Most frequent tests in cases of clinical, there are various guidelines, mostly guidelines, NICE guidelines, and various other universities have their own guidelines. To elaborate upon, I have considered one NICE guideline as one of the template here. More frequent tests in case of clinical deterioration, abnormal results, a change in sodium intake or symptoms suggesting abnormal renal or thyroid function requires for an estimation, a closer monitoring of lithium dose and blood serum levels. If urea and creatinine levels become elevated, they are called for. The assess the rate of deterioration of renal function, monitoring for symptoms of neurotoxicity, including paresthesia, ataxia, tremor, and cognitive impairment, which can occur even at therapeutic level because of these other indications coming in, that should be also kept in mind. There is an extensive experience in monitoring carbamazepine and valproate as anti-epileptics. Determining the serum levels of these agents required for mood stabilization is important. High levels of carbamazepine have been associated with the high rates of adverse event. In a study, it was seen that higher dose of carbamazepine and lower dose of carbamazepine did not produce any different result except for adverse events, while the therapeutic effect was similar. So routine measurement of valproate blood levels is not recommended unless there is an evidence of ineffectiveness, poor adherence, or toxicity, as it is a very well tolerated drug and has got a very broad spectrum. Routine monitoring of the blood levels of lamotrigine is not needed, and plasma levels of carbamazepine should be measured every 6 months to exclude toxicity because the therapeutic levels and toxic levels are close. In one of the studies I'll show you here, Bodin et al. Found that at day 5, the patients with valproate concentrations of at least 45 milligrams were 2 to 7 times as likely as patients with level of less than 45 milligrams to show at least 20% improvement in various mania scales. So it suggests that if an optimal dose is started and initiated early, then the response rate is very high, and a 20% response, which was higher on to the counterpart, that came in early because of this. But at the same time, when we look ahead, we said that there is no evidence of greater benefit from concentration of more than 45 milligrams. So that makes us understand that there is a very small margin of interplay wherein the doses are in a very narrow range, and a close monitoring get us to an optimal dose, and when we surpass that optimal dose, we go into the adverse event profile that requires and calls for a close monitoring. So toxicity was likely at 125 milligrams, so there was a huge difference. We are not talking about toxicity, but still, when we surpass the optimal dose, we see that the adverse event starts coming in. In practice, therapeutic concentration levels established for epilepsy are used as general guidelines for patients with bipolar disorder as well. Looking at sodium valproate, the relationship between sodium valproate concentration and mood stabilizing effect is poorly studied even till now. Therapeutic ranges for epilepsy are these, although the clinical value of this is controversial. When we look at carbamazepine, no therapeutic serum concentration for carbamazepine in bipolar disorder have been established. So at one time we are saying that these are the guidelines where we have these levels which are anti-epileptic levels which are acceptable to us, but because of the lack of data, there is no robust data which suggests them for mood disorders. So at the same time we have this dilemma coming in. In a study, CSF levels of the 10-11 epoxide metabolite of carbamazepine correlated with the antidepressant efficacy of carbamazepine in a mixed group of patients with unipolar and a bipolar disorder showed that there was no difference in recurrence rates in bipolar disorders patients between those with low or high carbamazepine levels. So even if we are treating them with a lower level and increase the dose, we are not going to have an additional benefit. Rather, we are only burdening with an additional adverse event coming in, or a side effect what we see. In practice, as for sodium valproate, therapeutic concentration levels established for epilepsy are used as a general guideline for patients with bipolar disorder for carbamazepine as well. So, what is the cost effectiveness we say, or the benefit of monitoring? Benefit in terms of the resources saved, like measurement of the serum lithium concentration is cheap and readily available, and if we use them in time, we can prevent side effects, and in turn the management of those side effects which calls in for further investigations and further treatment, that can be saved. So it is cost effective. The advantage: reduced likelihood of toxicity or severe adverse effect, reduction of recurrence rates by the establishment of the therapeutic levels, that is there. So to summarize, where would we see therapeutic drug monitoring to be beneficial? Firstly, when we are uncertain about the drug adherence of the patient, it calls for. Or we are looking at a person with suboptimal tolerability, or we are looking at a person who is non-responder at a therapeutic dose. So before labeling him into a non-responder, we would like to try and see whether the drug levels are correct. And pharmacokinetic drug interactions are something which are bothering us. It calls for an absolute therapeutic drug monitoring. And the population, as we had discussed earlier also, children, pregnant women, elderly patients, individual with subnormal intelligence, forensic patients, these are the groups which would be largely benefited. Patients with genetic pharmacokinetic abnormalities and patients with pharmacokinetically relevant comorbidities are those whom we are looking at. So therapeutic drug monitoring is an important tool for achieving greater control over the medication dose. Also, it helps in finding patient compliance and early signs of drug toxicity. And it is important in bipolar disorder, as well known, especially with drugs like lithium. Thank you very much for your patient listening.